What I'm kind of shifting gears, getting late, I'm sure a lot of people are hungry. I'll try to pace myself here. This is kind of shifting gears to the pediatric population, which is challenged both from standpoint of the adapting devices from the adult population, seeing whether they'll work or not, as well as just the challenge of economics driving the medical device industry. So what is referred as a renal replacement, so essentially a renal dialysis device intended for pediatrics, infants, newborns, all the way to adults. So the unmet need, this acute kidney injury in children, is actually rather common. A lot of times when kids come to the pediatric intensive care unit, they're critically ill, variety of reasons, as simple as jumping into the swimming pool on a hot day, they go into shock, the kidneys stop working acutely, but still it's necessary for renal function to proceed for just life. And it works out to over 3,600 patients, children a year, just in America alone. And a slow, gentle form of dialysis, continuous renal replacement therapy is preferred by many clinicians to treat these patients. And therapy is essentially you take cannulate the venous side and you get blood out, pass it through a semi-permeable artificial hemofilter that gets the ultrafiltrate, basically your urine out and through a pump, and then you send it back into the patient bloodstream. Now, it's common to infuse replacement fluid into the returning bloodstream to hydrate the patient after removal of the ultrafiltrate. Balancing these two is essentially sort of the mathematical problem here. And the concern or the need is that there's no FDA-approved CRT device currently in pediatric patients. And so that's the problem we're trying to attack here. So kind of to give a status quo of what's going on, in 2005, FDA actually had a class 1 recall of this particular device, the Camber Prisma, and they reported that there's several deaths and injuries because of this imbalance between the ultrafiltrated replacement fluid, as much as 60 cc's an hour just in adults. So you can imagine when you're dealing with infants or pediatric patients, the volumes are small, errors get worse. So since it's a cumulative therapy, their physiology gets affected every minute there's an inaccuracy. So it's not quite just doing it for a very short amount of time. They can be as long as 2 months till they recover their native kidney function. So the challenges are that clinicians adapt adult devices because there is anything right now to use, and there's a large volume that's demanded from these because they're used in adults, not children. And so that sort of propagates the issue downstream. You create secondary infusions because of transfusion, and fluid balance inaccuracy is widely noted. Nephrologists, ICU doctors, they don't know what to do. They're just doing the best they can. And problems get worse because 70% of these patients, or patients that need some sort of artificial heart-lung support, extracorporeal membrane oxygenation ECMO, they inevitably end up needing CRT as well. So when you take something that's one therapy that's not accurate, combined with another therapy that's also not accurate, you can imagine that everything goes out of bounds. The errors are really bad. And so current CRT devices don't allow for integration either. The clinicians essentially rake the circuit, they bypass alarms, they do whatever they can to make things work, but it's not safe, not convenient. And FDA, before I go back, they mandated putting a sticker on these machines saying that you can't use it on patients. But clinicians' dilemma is, do you follow the FDA regulation? Do you not give them life-saving treatment? Or do you give them this therapy, it's inaccurate, but just because the parents need to be answered? So what we said was we'll take that problem and we'll try to engineer a solution. The values from doing that goes to both the patient. Obviously, making a pediatric CRT device improves the clinical outcomes. You can expect that. and also opens up a whole new gamut of patients that cannot be treated. For instance, newborns right now, they have a really hard time getting treatment for this. And so potentially build patient populations from that. And also institutional. So for the hospitals themselves, the healthcare institutions, there's reduced liability because they are using something that's actually meant for that patient population and will be safe. So the objectives of this design, develop, and validate a pediatric CRT device. And to do that, we kind of abandoned the approach of looking at an adult device and trying to make things smaller, and instead just kind of thought of the problem as a pediatric specific problem. So from that perspective, we identified some goals, one being the very accurate fluid balance between the ultrafiltered UF replacement fluid, and more importantly, this is under low volumes. That's the challenge at hand. The other things are to be able to accommodate with the artificial heart-lung ECMO therapy and alarms that are meant for these patients, flow rates across newborns to adolescents. So a wide sort of across the spectrum objectives. And first thing though is to attack the fluid balance because that is a significant concern and unanswered problem. So what we did was we said, typically what these guys do is a couple of things. They use roller pumps, some form of peristaltic mechanism, IV pumps, and they calibrate it the same way, and then the machines have pre-built scales, and using those scales, they weigh one fluid and sort of control the other. So the problem with this approach is that the scales are very inaccurate at the low volumes that are needed, and it's not quite instantaneous. If you take a chart of how they do in time, it's all over the place. But in 8 hours, things get relatively okay. But the problem is the patient's kind of going through this dynamic up and down problem. So what we did was we said, to kind of abandon this idea, we want a low volume pump. And peristaltic pumps typically don't tend to be accurate. They're good because they're not intrusive, but they're not accurate. So we abandoned that concept. We tried to go into more of a syringe to diaphragm pump type concept. So this top version is the first generation of our fluid balance system. Essentially, we mechanically coupled the two pumps. So the idea being that if one is being driven by some sort of a motor, then the other one is following in pursuit, but they're moving in tandem. And the several generations past, now we have this essentially a crankshaft that couples the two. This crankshafts work, our automobiles run great. And so the idea being that the ultrafiltrated replacement fluid they're driven out of phase. So as one, the diaphragm is expanding to fill fluid, kind of like your heart, the other one's sinking out the fluid. So it maintains this balance, this delicate balance in time, allows us to size things down. The volume in this is about a teaspoon, so about 7 mLs. And the entire device, we didn't really go for miniaturization in the beginning, but turns out with just re-engineering the system, we can reduce the size of the entire device. Ours fits in a little bit bigger than a shoebox. And this kind of big assembly here, all the pumps are modular, so for sterility purpose, you can take one out, put one in, and they're easy, they're portable, they're easy to just plug and play. And we've also designed and developed a touchscreen interface for the physicians and the nurses, healthcare personnel, and that's got ready access to EMR integration. So current problem is monitoring these patients is kind of a hassle. We try to keep that information in all these layers in the system. And validation-wise, we kind of approached the sort of the most challenging version of this implementation, which is with the artificial heart pump. So the idea being that there's a pump that kind of does the artificial heart part and pulls fluid from a reservoir in the patient bloodstream, sends it through the oxygenator, and sends it back to the patient. We shunt that circuit, put this renal replacement loop in. This is kind of a common implementation across PICU units. And what we compared was using 2 IV pumps, which is what they use in Children's Healthcare of Atlanta. and many other institutions to our fluid balance mechanism, and they use flow rates that are similar or seen in neonates to adolescents, and the improvement is significant, over an order of magnitude reduction. Running these 2 circuits over 6 hours, what you see is the error in IV pumps, even though they're identically calibrated, this can be anywhere from 3 to 8%, and ours is less than 0.5% across a wide range of conditions, not shown in here, and they're repeatable as well. So some of the things we've accomplished is just by kind of redesigning the solution, the fluid balance are about over or an order of magnitude improvement, and the volume that we're using is substantially reduced to 34 mLs compared to 250 mLs. We can integrate with ECMO and actually tested it and validated it. Several are arms for neonates, pediatric patients, and adults, and ready access to integrating the data so physicians can manage it. And we're working on inline calcium monitoring sensors at the moment, and the way to redesign the hemofilter for not having coagulation issues as much. And we've kind of gone through several steps in the process, fortunate with funding. So it's moved from the conceptual design, that's where we started, with the Georgia Tech grant, to an NIH challenge grant, and now we're in FDA funding year 2. We're planning to do a healthy animal study in the spring, and we're looking for licensing or startup formation options. I'd like to acknowledge, take questions. Thank you.